All right. Well, it looks like it is officially 12:02. So I want to get us going. Again, thank you so much for everyone joining. My name is Robert Hess III. I am the owner of Hess III Consulting, and we are just so excited to have you guys here today. This is a part of our monthly Power Hour series. So every month we offer a different free training available to the community for y'all to share with your colleagues, come and join, and hopefully to collaborate and learn something with us. So excited to have everyone. Today, I'm super excited to introduce and hand this over to Alexis Santiago, who is part of our team. She'll be discussing, excuse me, progress note writing, really focusing on the essentials and helping folks, whether you are a peer support specialist, a case manager, a BHT, an RN, a medical assistant, anyone that is, working in clinical records on a daily basis. This training is for you. You still have a couple of minutes to share this with a friend if you want to get one or two more folks in here. But Alexis, do you mind moving us to the next slide just so I can talk about you a little bit and introduce you? So Alexis Santiago, who will be our facilitator, instructor today, is a good friend of mine. We've been working together for several years, probably 5, 6 years at this point. She brings over 20 years of experience in health and human services, specifically in behavioral health. You can see she is a licensed master's clinical social worker. I'm sorry, a licensed master's social worker, excuse me, and a certified professional of healthcare quality, which is a wonderful skill set. She's got a tremendous background as an accreditation surveyor, as a clinical records auditor, and she is also a professor down at Pima College, teaching this class as a 16-week series, which is really exciting. And so she's has quite the effort to condense that conversation into about an hour's worth of content for you today. So I'm going to stop talking and kick it over to her so she can kind of take us through her set. But thank you so much for joining us. Really appreciate it. And I will be managing the chat if any questions come in. Take it away, Alexis.
Thank you, Robert. I don't know about that whole introduction. I hope I do it justice. But like Robert said, I am Alexis. I have been around the block a little bit, and mainly focusing around quality and documentation has kind of been my area of expertise. So I have two caveats before we get started. One, this is not the most exciting information to share. Most people, when they hear about clinical documentation, they cringe. So it is not exciting topic, but I think it is a really foundational skill to have. And second caveat is I was a little overzealous on my slides. And so we may not get through everything, but I hope we will get through the most key points and important factors that you're hoping to get out of today. So with that, this is just an intellectual property notice. We have to have this in here. So skip through that. And then if you want to know a little bit more about Hess III Consulting, here's some information about our services that we provide. And so we're really excited to have you join us today. All right. So today we're going to kind of go through why compliant documentation matters. This is really going to be an overview and just general overview, back to basics kind of thing, best practices. Every organization is going to have different policies and procedures related to how things are documented or where they're documented or what template to use. So these are just general best practices. So we'll look at, assessment basics, service plans, and then the meat and potatoes of today's training is around progress note documentation and more focusing on the most common codes that we see billed. And then also tackling some of the most common errors that are seen when, for example, Access comes out to do an audit or other surveyors come out to do audits or your funding sources audit, the most common errors that we see. So why does it matter? So for those of you who are in a leadership role, money matters. And that's how you fund the services that the clients receive. And that's how you're able to pay your staff. And if you don't have good documentation, then sometimes, a lot of times, those through audits, you can have to pay back money, or you can get sanctions, or you're not getting paid for all the services that you are providing. So how the funding flows in general for behavioral health, especially, is, it comes down from CMS to Access, and then Access distributes it to the ACC REBAs, plans, and then other entities, and then it trickles down to the providers. So there's a lot of layers in oversight on our documentation and where the money's coming from. So there's a lot of places to answer to. So through the Covered Behavioral Health Services Guide, which really guides our documentation practices, the rules are going to come from various places. They're going to come from billing guidelines out of CMS. They're going to come from state rules. They're going to come from the Behavioral Health Services Guide. They're going to come from, depending on what type of organization you are, the licensure type you have, there's going to be rules around the documentation requirements. So under the Behavioral Health Services Guide, which really guides behavioral health practice and the services that we can provide to our clients, they fall into kind of three main categories. So you have your treatment services, which under there is mainly assessment and therapy. Those are the most common codes that we see. And then your support services is like case management, family support, peer support. You have your transportation, language services, and then rehab services are skill training and development, your peer support. Family support and peer support should be under rehab. And then your employment services. So when you're providing like pre-job training, interview skills, and then once your clients find and maintain employment, services to help them with that. By the way, I forgot to mention I'm from New York, so I talk really fast. So if you need me to slow down or repeat myself, let me know. I have no qualms about being told to slow down. All right. So we have our services, we have our funding that guides the services that we can provide. And then under those services, in Arizona, we have 3 different category types. So you're going to have, well, it's actually 4, but one is not mentioned on here, which is behavioral health medical professionals. So you have your behavioral health professionals, which are going to be all your licensed staff. So back in the day, years ago, prior to 2018, someone like me, an LMSW, I was actually a BHT. But recently, LMSWs are now considered behavioral health professionals. So a behavioral health professional is a licensed staff. And then you have your behavioral health technicians, which are non-licensed, bachelor's level, master's level staff, don't have a license. And then your behavioral health paraprofessionals are individuals without a degree. They may have specialized training. They may have a high school diploma with several years of experience in behavioral health. But based on your category type, your provider category will determine which services you are allowed to bill for. And then in addition to that, more layers, certain billing codes are going to have additional modifiers depending on your degree. So if you are a master's level provider, you will have some billing codes will have an HO modifier, and then some other bachelor's level will have an HM modifier. All right. With that being said, why does it matter to you guys? So understanding this information is, even if you're not a biller or a coder or in a leadership position where you have to worry about these things, it is important to understand your provider type, the modifiers, what services you can bill, because it helps to drive accurate billing. It helps to be able to demonstrate medical necessity for the services that are being provided. It helps to track outcomes. And most importantly, it helps with reducing fraud, waste, and abuse. There have been many times in various states throughout the country when Medicaid was doing their RAC audits, where the wrong providers were providing incorrect services, and all those claims had to be paid back because they were inaccurate and they were found to be fraudulent or wasteful use of money. So this is one of my favorite kind of concepts when you're thinking about documentation, is the golden thread. And so those of you who have been around a long time and have been in practice for a while, no matter what role you've all played a part in this golden thread in clinical practice. So you have your assessment, and the assessment is really the foundation of everything that we do as clinicians. It describes, why the client's coming in for services, what are their presenting needs, what are they hoping to get out of services? So why are they there? Who referred them? And then it helps to try to start to formulate what the goals of treatment are going to be. So it is really that foundation when you're building the house for your clients, or with your clients, I should say. And then that leads into the treatment plan, or the service plan. And that is really describes how we're going to help support the client to accomplish those goals that they were identified in the assessment, to help them address their needs, and always preparing them for discharge so that when you're not around anymore, they have the tools and skills to support themselves. If that same situation were to arise again, or that same crisis were to happen, they will be armed with the tools and skills that they need to be able to resolve those situations and address those needs on their own without having to have additional supports. And then the progress note, which for every clinician out there is in reality is the bane of our existence. It's the least favorite thing that we have to do on a daily basis, is writing progress notes. But the progress note is really the what. It helps to cover yourself as a clinician. It helps to protect the organization. And it really helps to demonstrate to anyone looking at the record, even the client, that these are the services that are being provided, why they're being provided, and it helps to track their progress in meeting outcomes, in meeting their treatment plan goals. So it is really a critical tool in being able to demonstrate that information. Because as we know, the old saying goes, if you didn't document it, it didn't happen. And, it is our way to protect that and also to demonstrate. You could be the best clinician in the world. And I've met over my years, amazing, amazing clinicians, and their documentation really didn't reflect their amazing work with the families and the clients that they've worked with, because their progress notes were lacking substance, or they were missing completely. So it is really that way to kind of tell the story on an ongoing basis. And then for those of you in the audience who are administrators and maybe are not practicing clinicians anymore, the reason that I feel that this type of training is so essential and foundational is because these same practices and techniques that we use in developing assessments, comprehensive assessments, in developing treatment plans, and writing progress notes are also techniques that you can use in your leadership roles. So when I stopped being a clinician, practicing as a clinician, and I stepped into a leadership role, one of the things I had to do was work on strategic planning. And so a strategic plan is just a treatment plan, but for an organization. And when you're, writing RFPs, it's an assessment. You're assessing your services, your needs, And then you're trying to help develop goals. And then your progress notes are those reports. So using these techniques or having these techniques in your toolbox can help you no matter what your role is, even if you're not a direct practicing clinician any longer. And if anybody has any questions along the way, feel free to take yourself off of mute and ask your question. Okay. So assessments. We're not going to get into the nitty-gritty of assessments here, but it is important to just, because it is the beginning of services, you can't bill for services unless there is an assessment on file that is current. So having a comprehensive assessment that kind of summarizes why the client came in for services, what their identified need is, what their history is, how long that problem has been happening, any noted behaviors or symptoms, and the frequency of that information, those symptoms, and having formulated your clinical impressions about the client's engagement and their need, and then also the treatment recommendations. Without that, the rest of the golden thread kind of breaks and falls apart. So you need a good comprehensive assessment in place that is current in order to be able to provide the services and then develop the treatment plan and then bill for those services. So as an auditor, that's the first place I go. Is I can tell you right now, as soon as I audit a chart, the first place I go is the assessment, and I flip to the end of the assessment and I look at the clinical impressions, the summary of information, and I look at the treatment recommendations. And I use that to start to track the next step. So I'll go there, and I go to the treatment plan or the service plan, and I look to ensure that the goals and objectives kind of flow and match from what was identified in the assessment. So having a good quality comprehensive assessment is kind of that essential foundational tool to get started. So I attended a recent access training, and they talked about assessments and some of the most common errors that they see. And these are really also the common errors that I see as an auditor when I'm auditing clinical records. So incomplete documentation, assessments not having the diagnosis, not matching really the need or the behaviors or the symptoms that were identified in the assessment. Incorrect use of standardized tools. So with assessments, there are, in addition, I should say, to the comprehensive psychosocial assessment, there are a ton of evidence-based assessment tools that are used with our treatment. So for example, the most common in substance use work is the ASAM. And then when you're working with children, the CASI. And so not using these tools to help support decision-making on treatment and recommendations and levels of care is one of the common errors that was noted. Using incorrect assessment code. So instead of using the appropriate assessment code for comprehensive mental health assessment, maybe you used the alcohol and drug assessment billing code instead. Or maybe you did a service plan, and instead of billing the treatment plan code, you billed assessment. So there's some, that doesn't happen as often, but it is a billing error. And then failure to link assessments to treatment goals. And we'll talk about that in a minute. So service plans. And you're going to notice I use service plans and treatment plans interchangeably because it depends on your organization, what you call them. So it's going to be the same name for the same tools. It's just your organization. So the key with service plans and where the most common errors, which we will discuss in a moment, is having a service plan that is linked to the assessment. So whatever the needs were in the assessment that were identified, making sure that they are linked to the treatment goals and objectives in the service plan. If the client came in for needing, substance abuse treatment, but their service plan, their goals and objectives on their service plan have nothing to do with that, and they're related to, I don't know, marriage and family therapy or something. Unless it was identified in the assessment, there's no link. And so having the goals and objectives really reflect what was identified in the assessment is key. And incorporating client words. So the service plans are for the client. We know as clinicians, when we're assessing a client, many times they will tell us, they will give us their story, what they're needing. And we know as clinically, we may say, if they really address, their underlying substance use issue, that would really have a ripple effect in improving their symptoms of depression or anxiety and their social interactions, and their family relationships and their workplace relationships. But the client is not wanting to address that as their need. They're wanting to focus on something else. And so having the service plans really reflect what the client wants is key to a good quality service plan. So using their own words, making sure the interventions are specific, making sure your objectives are SMART. Hopefully you guys have heard of the term SMART. So it's specific, measurable, achievable, realistic, and time-bound. So making sure that our objectives are written in a SMART format. We don't want to set up our clients for failure. We can't expect someone who is, drinking a 6-pack a day to, all of a sudden the next day, we're going to expect them to be completely sober and not drink at all. That is not setting them up for success. So we want our treatment plans and our service plans to reflect interventions and objectives and goals that are going to be achievable and that are realistic. Ensuring that we have, contributions from other folks. A lot of times our clients are always going to be the primary source of information, but many times there are external sources that can provide a breadth of information and background on our clients to help support them to be successful. So we have a lot of missed opportunities. So asking our clients who else they want involved in treatment and including them in those steps along the way, it really helps to support and strengthen the client's overall success. And service plans have to be updated at every 6 months or as goals change. And then medical necessity. You're going to hear that term medical necessity throughout everything we discussed today. And so having that, linking it back to being medically necessary is key. So most common errors are going to be, again, lack of medical necessity. Goals and objectives are kind of vague. They don't have member voice. And the most important is they're disconnected from the assessment. All right. So with all that being said, what you guys are all here for is progress notes. So some progress note documentation tips. So these are just some high-level tips of what a good kind of comprehensive progress note should have. It's going to have specifically what services are being provided. It should always have start and end times and duration. It should have who was there, where services are being provided. And this is key and is linking it to the treatment plan goals and objectives or the interventions that are being addressed. This is something that is often missed. With the development of electronic health records, this has become less of an issue in progress notes, because a lot of electronic health records have the ability for the staff person or the clinician to pick which objective or which intervention they are addressing in that appointment. But if your organization does not have that ability, having that documented in the progress note is going to be key. Describing the client's progress and your overall clinical impressions. And another thing that is often missed is the client's response to the services being provided. Using action verbs. And then this is more for electronic health records have this ability to stamp notes, but if a note is not completed on the same day the service is provided, that's okay. The note itself just needs to be stamped, or it needs to indicate that it's a late entry. Or if you're doing an addendum, it needs to have that language in there to show that it's an addendum. Okay. I'm not going to go over the billing rules, but this information is in here. If anybody wants to take a screenshot and needs to make sure that if you're having any issues with rounding, or if your claims are getting kicked back because of duration, this is the key for the 8-minute rule and the rounding guidance.
And actually, Alexis, this is Robert. We go back to that last slide. This has been such a hot topic in Arizona lately. And so I did want to take a quick pause and see if anyone had any questions about this. As most folks know, Access has reintroduced the 8-minute rule. This is an old rule that existed in 2017. And then, it hasn't existed for a while, so it feels new to a lot of people. So specifically, the breakdown of those units and how we bill them. Are there any questions on that particular topic, just because of how relevant it is? And again, you can take your hand, come off mute or raise your hand.
Hey, Robert, this is Sharika. So not necessarily a question around it, but we are telling our staff to continue to bill with the hopes that there are some other services maybe provided same day where they can be counted in the roll-up. The other opportunity we have is billing under the new outreach code under 8 minutes, any under 8-minute engagements.
Yep, that's a great call out. Thanks for bringing that up and highlighting it, Sharika.
So that is the key to this 8-minute rule. Even though the language says, it has to, if it's not 8 minutes, then you can't bill it. It means cumulative, and it means it has to be the same service code. So if you're providing, like in this example, multiple phone calls about a client because you're coordinating care, all those minutes will add up. And as long as they add up to more than 8 minutes or more in the day for the same code, then it counts as billable. But you can't use 2 different codes. So if you can't use case management and something else to add up to that 8 minutes, it has to be the same service in the same day for the same member. Okay. So I don't know. You could raise your hand. Are there any folks on this training that provide counseling or therapy? Because if there's not, I will skip over the therapy services.
Yes.
Okay, perfect. Thank you. So teletherapy became a big thing. And so the only thing I want to point out in here is there's specific language that has to be at the beginning of every progress note if you're providing it through teletherapy. So if you're doing teletherapy, if you're doing any services via Zoom, you have to have this language in here. And so this is an example of the information and how to make sure that you're meeting all the criteria. So if anybody wants to take a screenshot of this, it's handy dandy. Okay, so there's tons of different progress note templates out there. Most of us have heard of SOAP. Most of us have heard of DAP. I personally prefer DAP only because as a clinician, I could never wrap my head around what information needed to go in the subjective section versus the objective section of a SOAP note. So I personally prefer DAP, but you can use whatever format you want as long as the progress note contains certain elements and certain information. So I'm going to use DAP as an example, but just keep that in mind that as long as your note template contains this key information, you'll be fine. So in a DAP note, the data section is really just the facts. In there, we want to know who was present, where the services are being provided, what services are being provided. So we're great about doing that and documenting that in progress notes. Where I see the most common errors is why. So why are we providing those services? And this is where if your electronic health record has the ability to have the service plan up for the clinician or the care coordinator or, the specialist to be able to pick from, helps tremendously. But you have to demonstrate why you're providing that service or document why you're providing that service and linking it back to the service plan, objectives and interventions and goals. Other things you need to consider in the DAP section is, why are you there? What is your role? And what the client is reporting. This is just facts, not opinions. What strategies you're using. If you're providing services in another language or you're using ASL, this is also where that will be documented. If you're providing it through teletherapy or telehealth, this is where you're going to document that statement about being via a compliant, HIPAA compliant connection. So this is just facts. The assessment section of a progress note is where you as a clinician, as the practitioner, will really put in your clinical impressions about everything you heard and saw and observed, and that's documented in the data section. Then you take that information and you document your impressions about the client's behavior, about, their speech, about their physical appearance, their motivation, their progress and lack of progress, their response to services, their response to the services that are being provided, their response to the techniques they're being taught, their response to the session, and also their engagement or lack of engagement overall in their treatment or their services, and any additional client needs and any additional recommendations that you're making. So based on your impressions, based on everything you heard, you saw, why they're there, what services are being provided, do you have any other recommendations? Does the client have any additional needs? Because that's going to help guide the next section, which is the plan. So the plan is the easiest part of a note to complete. It's what are the next steps? So do they have another appointment coming up? Are you going to make a referral for the client? Does the client have any homework they have to do? Or is it all of the above? Where the plan section tends to lack is I will see a lot of generic statements in the plan section of a progress note. So don't use, we'll continue services, we'll monitor, we'll follow up, don't stay away from those generic kind of statements. And even if it's just, we'll meet with client in 2 weeks on, November 15th at 5:00 for our scheduled, 2-week check-in. that simple. But staying away from those kind of generic statements. So the most common errors are
Excuse me,
missing.
I have a quick question about the DAP note, where you had said to not use the generic phrases like, will follow up. Would it be suitable to say this writer will follow up with SMI case manager to coordinate care? Or is that still too vague?
It is good. It just is missing by when. So give yourself a time frame. Even if it's going to be in 2 weeks, putting that time frame in there helps to track accountability, and also for yourself, because when you remember, oh, I was supposed to follow up with somebody because it's in your note. So it keeps it more specific. So just adding a date into that sentence will change the whole thing. Good question. Any other questions? All right. So treatment services. So for those of you who are BHPs or BHTs, you're allowed to complete the assessment. So the most common treatment services that we see are assessments, the service plan development, and therapy under this category. And this is where, again, we're gathering that information. We're really setting up the foundation of services. And then most clients will have some kind of counseling or therapy, even if it's group, as part of their treatment. There is a new service code. It's service plan development. It's 80032, and I have all the codes in here for you guys, so you just have that as a reference. This service code can only be provided by BHPs. So even if you're a BHT who's completing a service plan that is being signed off by your supervisor, who is a BHP, or is a licensed clinician, you cannot bill the service plan code. So this service plan code can only be billed by BHPs. If you are a BHT who's completing an assessment or completing a service plan or a treatment plan, it has to be signed off by a BHP, reviewed and signed off by a BHP within 72 hours. So if that's on paper, or your organization has an electronic health record, there has to be a mechanism in place for those assessments and service plans to be reviewed and signed off by a licensed clinician. Okay. So,
I have a question.
Mhm.
So with the 72 hours, is that just business days or does that include weekends? So if like I did an assessment treatment plan today on a Friday, 72
it's
hours would
business.
be Monday,
Yeah, it's business.
right?
Mhm.
I just want to clarify.
Yep, it's business hours. Not calendar days, not calendar hours.
I have a question about that as well. Is it based off of the BHT or BHT's signature that it starts the 72 hours, or is it?
Yes.
Okay, not the assessment, say date of service was today, we completed it, but the BHT didn't
Right.
sign until tomorrow, then it starts 72 hours from tomorrow?
Yes.
Okay, awesome. Thank you.
Yes. From when it's completed, because again, you may start an assessment on 1 week. Like when I worked out in the organizations, we allowed our intake workers to have 2 appointments to complete the assessment. So the assessment wasn't completed until 2 weeks later. So the initial date of the assessment was on one day, and then it wasn't completed until 2 weeks. And then the clinician would complete it, and they go to the supervisor for that review and signature. Okay. So the other caveat with assessments, and this is always tricky when you have a client that goes to another level of care, and then they're discharging to you, for example, is the assessment code, the H code, can only be billed once per day per member. It doesn't matter the provider. So whatever organization gets that assessment code in first is the one that's going to get paid. And then your organization, if you got it in second, is going to get kicked out. So it's only allowed one per day per member. It doesn't happen that often, but I needed to put that out there so that you guys are aware. Okay. And I'm not going to go through these, but these are all the different assessment tools that are allowed to be billed under the assessment code. All right. So here is an example of an assessment code. And I tried to call out for you guys the key points that have to be in a progress note. It doesn't matter what code you're billing. These are all the things that, as a reviewer, as an auditor, are key to demonstrate that that note is billable and meets the criteria to be billed. So client, having your client name and the clinician, that's the who, participating in a session to complete a comprehensive assessment, that's the what. And at the outpatient behavioral health clinic, that's the where, following the initial intake. During the session, the clinician and the client reviewed presenting concerns, anxiety and sleep disturbance, and explored psychosocial, medical, and behavioral health history, which is the how, to identify contributing factors and determine level of care. The purpose of this process was to gather and evaluate information necessary for diagnostic impressions and treatment planning. That's the why. And then if you did any other assessment tool or you had any other screening forms completed, you're going to list those also in the data section. And then in the assessment. So clinical impressions indicate that the client demonstrates insight into symptoms and motivation for change, supported by evidence from standardized measures and observed behaviors. So your clinical impressions, no matter what they are, and you don't have to use the word clinical impressions, but you have to have evidence. So you can say as evidence by, but what is your evidence to support those impressions? If you think about it as if I was on the stand in court and, the attorney asked me to justify why is that my clinical impression? I can't just say, well, because I'm a licensed clinician and, that was my impression. It has to be based on some kind of facts, some kind of evidence, and you need to document that in the assessment part of your note. So the PHQ-9 score of 14 indicates moderate depressive symptoms, and GAD-7 score of 12 reflects moderate anxiety. So again, we have that evidence of why the impressions are being supported. And then, client was engaged throughout the session, receptive to feedback and verbalized understanding, expressed confidence and ability to implement strategies and relaxation techniques between sessions. So that's the client's response to the assessment service that was being provided. And then we have the plan. So the key with a billing assessment is documenting what areas of the assessment were being completed. If you're not going to complete the comprehensive assessment in one appointment and you're doing 2 appointments to get that assessment completed, in each note, you should, in the data section, it should reflect what was done, what areas of information you gathered, what additional assessment tools you used to reflect and support that assessment code being built. So I'm going to skip through most of the therapy stuff, so therapy and counseling could be provided by BHP or BHT. It could be provided in the home, it could be provided via teletherapy. and interactive. So with counseling, I think the key point with counseling is really, this is where you're going to make sure that you're linking it to the treatment plan goals and objectives. And it should be reflected in that. The reason you're providing counseling or therapy is to address what from the assessment, what from the progress, the treatment plan, what are the client's symptoms, diagnosis, their goals. So why are you providing it? And how are you providing it? What I would see in here in progress notes by therapists or clinicians is sometimes the progress note was too theoretical. As an auditor, as a former clinician, I don't care, not that I don't care, but I'm trusting your clinical judgment on which therapeutic modalities and techniques are going to be most appropriate for the client. What I'm looking for in a progress note is, when it comes to therapy, is more that what type of therapy you're providing. Is it individual? Is it family? Is it group? Why are you providing that therapy? What are you trying to address? What symptoms, what behaviors are you trying to address in that session? And then how are you doing it? Again, is through just by providing therapy. And then if you're providing any techniques, is also how. So in this example, client attended a 60-minute individual therapy session with who to address symptoms of anxiety, improving coping skills. So that's the why. And if I go back to the service plan and the treatment plan, I should be able to see that as objectives, identified objectives in the service plan. And then in here, if your electronic health record doesn't have the ability to link your progress note to a specific objective or intervention, this is how you could write it out. So the session focused on the treatment plan objective, and then just copying and pasting it in from the treatment plan. Client will learn and apply 3 coping strategies to reduce anxiety symptoms from 8 to 10, from 8 out of 10 to 4 out of 10 within 90 days. So that's just a copy and paste in. Easy way to check the mark that you've addressed that progress note requirement. And then the how. Then we get into, again, the impression. So the client presented with mild anxiety at the start of the session, evidenced by, there's that evidence, fidgeting and rapid speech. Those are your clinical impressions. The client engaged well in interventions demonstrated by the ability to identify automatic negative thoughts and challenge them with the therapist's support. The client actively participated, verbalized understanding of coping strategies, and expressed confidence in applying deep breathing outside of therapy. That's the client response. One thing I forgot to mention way in the beginning and in your notes, if you were a student of mine, I would forbid you from ever using the word coping skills in your documentation. So the reason that is one of my forbidden words or terms is because I think it's overused, and it has become a common error in documentation when being audited. So you can use coping skills or coping strategies like that in your documentation, as long as, even if it's in parentheses, putting exactly which technique you're asking the client to practice, which technique you're teaching them. Of the dozen or so techniques that we know as coping strategies or coping skills, which specific one are you using? Because that also helps us as clinicians to demonstrate to the outside reviewer that it's clinically appropriate or medically necessary. Those techniques were medically necessary, and they're individualized to that client. You may have 15 clients on your caseload, all with depressions, all with similar histories and backgrounds. But in order for us to demonstrate that their services are individualized, that's the way we do it. Instead of using generic terms, we use more specific terminology in our documentation. Okay, so for those of you who are providing group counseling, the key with group counseling progress notes, and I'm trying to keep an eye on the time, and I knew we were going to run out of time. So the key to providing group counseling is in your group of 10, let's say, clients that are participating, the data section can be the same. So you're going to say, you know, how many people were attending in the group, what was the topic of that group session, which session number is it, and what was the purpose of providing that topic. So the data section for all 10 group participants can be exactly the same. Where your progress note has to be individualized is in the assessment section of that note. So in the assessment section of a group note is where you're going to identify the client's response, that individual client's response to that group session, and then your clinical impressions about that specific client and their interaction and engagement in that session, that particular group session. And then the plan section can be the same. So data and plan could be the same for all group participants. It's the assessment section that has to be individualized. All right. And I'm going to, unfortunately, skip a lot of this because I was really overzealous. And I think there are some peer support folks on the call, maybe some case managers on the call. Is that correct?
That is correct.
Okay, so I'm gonna skip to just case management and peer support, and then I'll give us a few minutes for questions, if that's okay with everyone. So case management. Case management is like the catch-all kind of code. And one of the easiest codes, but it's also a difficult code to have a good quality progress note because of the why. We're really good about what we're providing, case management, and how we're providing it, you know, but it's the why. The why, it doesn't matter the service code, but why is always the trickiest thing. So if you were doing a case management service, providing a case management service, an example of a good quality note is, you know, you providing care coordination, that's the what you're providing, and the why, to address barriers impacting treatment engagement and daily functioning. Still needs to be tied back to the service plan, but that's an easy way. As a case manager, as a care coordinator, that's the role, is to coordinate care, to make sure the client has all the resources they need to continue to engage in treatment. If there are any barriers to treatment, or if they are not engaging in attending appointments, you know, having that documented. And then your clinical impressions, having that documented again, you know, what was their presentation like? How are their symptoms? What did they say about their symptoms? And what evidence do you have to support that? And then peer support. So peer support can only be provided by a certified peer support specialist. So even if you're a BHT, if you're not a certified peer support specialist, you cannot provide peer support services. And an example of a peer support note is, you know, you're providing peer support services, that's the why. The purpose is to support members' recovery goals by sharing lived experiences, modeling coping strategies. And if this was a good note, I should take my own advice. I would be specific in here and saying what coping strategies, and facilitating connection to the community resources. And then how, this is where, you know, specifically identifying those coping strategies. So specifically the session included role playing on how to ask for help and practicing a grounding exercise together, specifically 5, 4, 3, 2, 1. and then why you're doing that to help the member stay present and reduce anxiety. And then for peer support specialist, member was initially hesitant, but became more engaged as the session progressed. That's the client's response. And then member demonstrated understanding of grounding techniques, expressed hope after hearing the specialist recovery story. So, and then the member is building trust and motivation for recovery, evidenced by willing to participate and ask questions. So that's your clinical impressions. So fortunately, we're not going to get to rehab services, which is skill training and development, the employment services, so ongoing support to maintain employment services. We will, Robert, will we be sending a copy of this PowerPoint out in PDF?
We'll be posting a recording and we can send out a PDF, absolutely.
Okay, so just because we didn't get to all of the topics, I wanted you guys to have the resources available to you to see what the code is, what's the purpose of the code, and then I have examples of how to write a progress note to meet that code for you. But at the end of the day, the only thing I really want to say about progress notes is if you can document in your progress note those whys and how. So who was there, the W's and how. So who was there, where it was, what did you provide, why did you provide it, and how you provided it, and then having your clinical impressions and the client's response, you're going to have a good quality progress note that any auditor would be happy to say it meets the documentation standards. And yes, it was appropriate and it was found to be medically necessary. So any questions? I know that was a lot of information and we didn't get to all of the nitty gritty, but are there any questions burning on your heart right now that I can answer? And I really, thank you. And I'm sorry we rushed through this. I'm a talker. And there's so much information to provide. And so I really, it's unfortunate I couldn't get through all of the different billing services, but any questions that I can help answer? All right. Well, in this, when we send out the PowerPoint that there's a list of resources